Alright, so we're back and we're going to talk here about diseases that infect the respiratory tract. And we're going to talk about all the respiratory infections besides tuberculosis here. And we're going to focus on bacterial causes, primarily because we're going to focus on some of the fungal causes later, and the viral causes generally don't need to be treated. So what do all of these have in common? We're going to talk about three primary diseases: bronchitis, pulmonary abscess, and pneumonia. And they're all three separate pathological pathways, but they all have three things in common, and that is that they all tend to present with fever, sputum, and cough. So you could call sputum and cough a productive cough, but fever, sputum, and cough are the triad that people tend to present with. So bronchitis is an infection of the airways themselves, whereas pneumonia is an infection of the lung tissue. And a pulmonary abscess is just that. It's an abscess of the pulmonary tissue. It's focal. So what all of these have in common is that they create, because the nature of the fact that it's an infection, it causes sputum to be released, and that's coming from the lung cells itself as well as from infected tissue. The fact that there's an infection here, there's irritation to the nerves, that's causing a cough, and the infected tissue is releasing inflammatory mediators such as interleukin-6 and interleukin-1, and those both cause fever, as well as many of the other inflammatory mediators that are being released. So sputum, cough, and fever are the three things that we see all the time in respiratory infections. We're going to talk about these now individually. So the offending organisms vary, but primarily for acute bronchitis, it tends to follow along the same lines as sinusitis. So 40% are strep pneumonia, 30% are Haemophilus influenza, 20% are Moraxella catarrhalis, and 10% are other or undiagnosed. As far as pulmonary abscess, it's going to be anaerobes most of the time. 90% of the time it's going to be anaerobes or anaerobes with aerobes. So important for pulmonary abscess that you remember that we're treating anaerobes here, whereas with the other ones we tend to be treating aerobes. With pneumonia, there are a lot of causes. Strep pneumonia in adults being the number one cause, but viral being another prominent cause, mycoplasma pneumonia being a very prominent cause in young adults and in teenagers, chlamydia pneumonia, Haemophilus influenza, Moraxella catarrhalis, Legionella pneumophila, Pseudomonas aeruginosa, Staph aureus, and then we get down to some of the very, very uncommon causes. P. girovecchi, which we see in HIV and AIDS patients, C. burnetii, which we see in patients who are exposed to the placenta of sheep, so you can imagine that's pretty uncommon. Klebsiella pneumonia, which we see in alcoholics, Francisella tularensis, which is seen in patients with exposure to rabbits. And then the various fungal causes, which we're not going to address here. We're going to devote an entire set of slides to fungal diseases. And of course, we can't forget strep A. galactiae, which is the GBS group B strep, and this affects neonates 0 to 2 months of age. This is vertical transmission. Alright, so acute bronchitis. So this is an infection and inflammation of the bronchi, primarily the upper airways, and the hallmark symptoms are going to be, as we mentioned, fever, sputum, and cough. Now we have to differentiate between acute and chronic bronchitis. Acute bronchitis really anybody can get. You've probably had it yourself. Chronic bronchitis, on the other hand, is a part of COPD along with emphysema, and generally it's going to be seen in patients with certain risk factors. The most common one that you've surely seen is smoking. So the 80-pack-a-year smoker that's in the hospital for an exacerbation of chronic bronchitis. that's something that you'll commonly see. Something less common that can cause chronic bronchitis, perhaps cystic fibrosis, perhaps alpha-1 antitrypsin deficiency. The diagnosis for acute bronchitis, so anytime a patient comes in with a fever and they also have a cough, that's always an indication to do a chest x-ray. And indeed, in acute bronchitis, chest x-ray is indicated, but the chest x-ray will be normal. And the reason is because we can't really see inflamed tissue in the in the respiratory tract, in the bronchi. We can see diseased tissue in the lung parenchyma, but that's not where the infection's going on. Here it's going on in the bronchi, and so the bronchi, while they'll be inflamed, they'll look normal. So when a patient has a fever and a cough, even though the chest x-ray is going to be normal, what we're really doing is we're just ruling out pneumonia. And once we rule out pneumonia, we're going to go ahead and treat them for acute bronchitis. The fever and the cough with the normal chest x-ray will be enough, and we're going to treat them with amoxicillin. We can substitute that with a macrolide if they are allergic to amoxicillin. But otherwise, amoxicillin is the antibiotic of choice. We treat this just like sinusitis. If the case is mild, we can actually go without antibiotics, but most patients, again, since they're coming into the hospital, they're coming into the clinic, they're usually going to want something for it. Okay, chronic bronchitis, we'll just give this a brief talk. Chronic bronchitis is an exacerbation of COPD. And the diagnosis will be the exact same way. It'll be a chest x-ray to exclude pneumonia. And of course, it'll be normal chest x-ray, except you'll see some of the features of COPD, which would include hyperinflation and barrel chest, etc. The treatment here is going to be the exact same as acute bronchitis. Amoxicillin is generally the first-line agent. You could also go with doxycycline or trimethoprim sulfamethoxazole. A lot of times, because patients with chronic bronchitis, sometimes they have more drug-resistant strains, but amoxicillin is perfectly fine. Now, if you have a patient where they've been treated for chronic bronchitis and they've had recent antibiotic use, say within the last 2 weeks, then you should use an augmented amoxicillin, so amoxicillin clavulanate. You could also use a macrolide like erythromycin, or you could use a fluoroquinolone, respiratory fluoroquinolone like moxifloxacin, or you could use a second or third generation cephalosporin like ceftriaxone. But just know that you should use an augmented amoxicillin or a different agent if the patient has had a recent antibiotic use. But the first line of therapy in general for chronic bronchitis is amoxicillin, just like in acute bronchitis. All right, so pulmonary abscess. So pulmonary abscess, as we mentioned, is a focal contained infection of lung parenchyma. And this is seen in specific patient groups because generally you don't just aspirate your own vomit. That's not something that most healthy people do. And so some of the risk factors are going to be alcoholism. So alcoholics have a tendency to pass out and they have a tendency to vomit because of the alcohol. So you combine those two and you can imagine how they would aspirate. Aspiration itself, loss of consciousness. Patients who have seizures, they do also have a tendency to vomit, and since they have a loss of consciousness, they might not be able to control where that vomit goes. Patients with poor dentition, just simply for the fact that this is something that's caused by anaerobes, and having poor dentition, you increase the amount of anaerobes in your oral flora. And then, of course, intubation is also a risk factor, which is why we have patients go NPO before surgery, because we don't want them to aspirate, and pulmonary abscess is one of the complications of aspiration. So again, you're going to have a hallmark of fever, sputum, and cough. The sputum here will often be putrid, but you might not always see that, and you might not always know that. But certainly if a patient has sputum, it might not be a bad idea to give it a whiff or have the nurse do it if you don't want to. That's certainly one of your perks. And in these patients, compared to pneumonia, most of the pneumonia cases and bronchitis, the fever will generally be higher because there's a larger focus of inflammation. The diagnosis here again is going to be chest x-ray, and here we'll actually see something. We'll see a focal cavitation with or without an air fluid level that's visible, but the focal cavitation is going to be what's key. The treatment for any pulmonary abscess is going to be clindamycin, and clindamycin is good for any above the diaphragm anaerobic infection. Drainage is rarely needed for a pulmonary abscess. Generally, the antibiotic will be enough, but the most accurate test would be a drainage because it would confirm that indeed you have an infection that's causing the abscess, and you would also see liquefactively necrosed tissue as well that confirms the abscess. So this is an example of an abscess. This is a classic example in which you see primarily what you're going to be looking for is you're going to be looking for the wall of the abscess because most of the tissue behind the abscess looks pretty normal except for this air fluid level. So this fluid here is necrosed tissue, pus, etc. But this is the wall of the abscess, and this is quite a large abscess, probably about 3 to 4 centimeters. So here's another abscess in a patient that appears to have COPD. This, on the other hand, you don't have an air fluid level, but you can see that you have an abscess here because you can see the walls of the abscess. So here's your abscess here, and it extends probably about 5 centimeters here. And then here's an abscess in a pediatric patient. Again, you don't see an air fluid level. You don't have to, but here's the wall of the abscess here. And it's actually pushing the heart over into the right lung field. Okay, so pneumonia. Right now we're going to talk about community-acquired pneumonia, which is going to be the majority of pneumonia you see. This is just pneumonia that's not caught in the hospital. Pneumonia that a patient does not develop while they're being hospitalized. So pneumonia is a general infection of the lung parenchyma. On the other hand, we were talking about abscesses. That was a focal infection of the parenchyma. This is a generalized infection of lung parenchyma. So the risk factors include cigarette smoking, fluid in the lungs for one reason or another, a splenectomy, which we'll talk about why that is in a little bit, immune status, namely a low immune status, age greater than 60 or less than 2, and alcohol consumption. I can't stress most enough that the most common cause of pneumonia among everybody is Streptococcus pneumonia. So yes, among alcoholics there's an increased incidence of Klebsiella pneumonia. Yes, among people who have been around bad air conditioning there's an increased risk of Legionella pneumonia. Yes, among patients with cystic fibrosis, there's an increased risk of Pseudomonas. But the number one cause in all age groups is Streptococcus pneumonia. Now, when I say all age groups, I'm excluding children here. So we're primarily talking about internal medicine. Obviously, in children 0 to 2 months of age, the number one cause is GBS. So the symptoms, again, are going to be sputum, fever, and cough, just like any other lung infection. Sputum may or may not be present. You don't have to have it. And indeed, in some of the atypical pneumonias, which are the non-streptococcal pneumonia primarily that I'm referring to, you may not see sputum. But definitely a fever with a cough is an immediate indication for a chest x-ray. So it really doesn't matter if the sputum is there so much because any patient with a fever and a cough is going to be getting an x-ray. On physical exam, this will be really, really prominent. You'll hear rales and rhonchi. You can hear dullness to percussion if you actually percuss the lung fields, and you can hear egophony over the lung fields if the patient actually has a lobar pneumonia. So for diagnosis, as we mentioned, chest x-ray is the standard, and that will generally show lobar consolidation, which is how streptococcal pneumonia works, which is the most common pneumonia. Others will tend to show more diffuse infiltrates. So lobar consolidation means it's just a pneumonia that's consolidated, restricted to one lobe. And so you'll see that just a streak of the lung field is infected, whereas the rest of it appears to be normal. The diffuse infiltrates will be more generalized. So here's lobar pneumonia. This one's not a very obvious case, but you can see it right here. It's the right lower lung field here. Here's a more apparent cause or picture. So this is the right middle lung field. And then here's another more discrete one on the left side here. Now here's an interstitial pneumonia. So this would probably not be streptococcus pneumonia. And this you can see it's infecting the entire lungs. So how do we treat community-acquired pneumonia? First, we have to determine whether or not the patient has to be admitted, because whether or not we're admitting the patient actually is going to change how we are supposed to treat the patient. So the question then becomes, when do we admit the patient? We admit any patient that shows respiratory compromise or sepsis. So if the patient needs to be in the hospital to be stable, then yeah, we have to admit them. That's the rule of thumb for anybody. If they have to be in the hospital, then they got to stay in the hospital. So a patient with hypoxia, hypercapnia, or tachypnea, these are all patients that should be admitted. Patients that are showing signs of sepsis, so if they've got hemodynamic instability, low blood pressure, tachycardia, they should be admitted as well. As a general rule of thumb, we're going to admit any patient over the age of 65. And patients with significant concomitant illnesses, such as cancer or COPD or congestive heart failure, or patients with immunodeficiencies, such as HIV, AIDS, or asplenia, or if they're on steroids for one reason or another, they should also be admitted. Later on, I'm going to show you, you don't have to watch it, it's the CURB 65 score. It actually gives you a score of whether you should admit somebody or not. But the general rule of thumb is, if they've got respiratory compromise or sepsis, always admit them. Generally, patients over the age of 65, you should admit them, or if they have a concomitant illness or immunodeficiency. Now, how severe the disease is, I would say always respiratory compromise or sepsis, they should be going to the ICU. The rest of them who need to be admitted, they can be admitted to the general wards. And if they don't need to be admitted, you can obviously discharge them. So, as far as emergency care, we're going to give them oxygen assist as necessary. If we need to give them oxygen assist, generally, of course, they're going to be inpatient. And then fluid resuscitation in the case of the patients who are showing hemodynamic instability. So always remember your ABCs first. Some patients may even have to be intubated. Okay, so let's say that we had a 19-year-old patient. He's hemodynamically stable. He doesn't need oxygen assist. He's just got fever and sputum, and he's got lobar consolidation on chest x-ray. Otherwise, he's doing fine. For outpatient therapy, we can give either a macrolide or a fluoroquinolone. So one or the other, and this is oral therapy. So this is the easiest way to treat because it's oral. And macrolide, we can use either azithromycin or clarithromycin. And fluoroquinolone, we can use moxifloxacin or levofloxacin. Those are the respiratory fluoroquinolones. Another fluoroquinolone is gadifloxacin, but that's in only IV form, so we can't give that PO. So a macrolide or a fluoroquinolone. Now, if we have to admit the patient, then we can use a macrolide or a fluoroquinolone as well. But if we're going to use a macrolide with an inpatient, we have to add ceftriaxone. So ceftriaxone and a macrolide, or we can just use a fluoroquinolone for a patient that's admitted. Now, if the patient has severe enough disease to where they need to be admitted to the ICU, then our therapy changes. We can use, we're going to use a beta-lactam in all cases in the ICU, and that's generally to cover Pseudomonas. And then we can do the beta-lactam and macrolide. We can do the beta-lactam and fluoroquinolone. Or if the patient happens to be allergic to beta-lactam antibiotics, so if they're allergic to penicillin, then we can substitute the beta-lactam with aztreonam, which, as you may remember, is only effective against gram-negative drugs. So beta-lactam and macrolide, beta-lactam and fluoroquinolone, or fluoroquinolone and 3. Now, in any inpatient or ICU setting, you should consider adding anti-pseudomonal coverage if the patient has risk factors for Pseudomonas. And primarily what I'm talking about here is patients with cystic fibrosis or patients with immune deficiency such as HIV and AIDS, patients who are on steroids, patients with other immunodeficiencies. So the anti-Pseudomonas drugs that we use are piperacillin tazobactam, ticarcillin clavulanate. Those are both beta-lactam drugs, so we try to avoid those in patients who have penicillin allergies. We can also use some of the newer cephalosporins, ceftazidime, which is a third-generation cephalosporin, cefepime, which is a fourth-generation cephalosporin, and particularly is noted for its anti-pseudomonal coverage. And we can also use tobramycin or amikacin. Those are both aminoglycoside antibiotics. As far as the supportive care for patients with community-acquired pneumonias, we want to make sure that they're getting chest physiotherapy, just simply because if they're not breathing as deeply, which they tend not to because it's painful, it causes them to cough, they're at risk for developing further pneumonia or atelectasis. So we want to have them on incentive spirometry. Oxygen monitoring is always important because if they have a deterioration in status, then it's going to change our game plan. Oxygen supplementation, we'll try to wean them down on their oxygen supplementation, but initially oxygen supplementation is going to play a big role. Antipyretics, analgesia, proper hydration, diet and activity, etc., etc. Base your progress on the patient on their symptom resolution and on radiography. So if the patient is in the ICU, they should be getting chest x-rays every day. If they're in the general wards, they should be getting chest x-rays every day to every other day. Okay, so what's hospital-acquired pneumonia? So this is in patients who are already in the hospital for another cause, and so technically more than 48 hours, and then they've begun to develop symptoms. And hospital-acquired pneumonia is a separate entity because the causes are different. So there are lots of different bugs floating around in the hospital. There's a lot of sick people in the hospital. And so the possible causes of pneumonia when you acquire it in the hospital are different. And so the way we treat it is going to be different. Here, just as in community-acquired pneumonia, it's going to be important to get sputum cultures, but the sputum cultures, because they take time, are not going to dictate your treatment. We're going to treat empirically. But you're going to want to have the sputum cultures just in case your empiric therapy is not effective. Patients with hospital-acquired pneumonia should always be treated with coverage for Pseudomonas and for methicillin-resistant Staphylococcus aureus, whereas in patients with community-acquired pneumonia, that was more of an option. With hospital-acquired pneumonia, it's a necessity. So the anti-pseudomonal drugs, as mentioned, were ceftazidime, cefepime, piptaz, ticarcillin clavulanate, tobramycin, and amikacin. And the anti-MRSA drugs include vancomycin and linezolid. So they should be on one of each of these, so an anti-pseudomonal and an anti-MRSA. You can also go ahead and add a fluoroquinolone as well. But as far as USMLE is concerned, you've got to have patients who have hospital-acquired pneumonia on an anti-pseudomonal and an anti-MRSA. And these drugs are broad spectrum enough that they would take care of the other community-acquired causes of pneumonia. So there are some specific pneumonia causes that are associated with certain etiologies, but they're not extremely common. Remember that the most common cause of pneumonia in adults is streptococcal pneumonia. However, these pneumonias are associated with risk factors, so when you get vignettes on the USMLE, a lot of times when they want you to think of these specific pneumonias, because they do exist, they will give you certain scenarios. So mycoplasma pneumonia is the most common, I would say, out of these specific pneumonias, and it actually is the most common pneumonia in young adults and in teenagers. And this is what's known as the walking pneumonia. It has mild symptoms, just like a cough or low-grade fever. A lot of times it's a non-productive cough. A lot of these patients will say that they feel like they have a cold. But then when you realize that they have a cough and they've got this fever, and you get an x-ray, and a lot of these patients, they don't wind up getting x-rays, but when they do, it's actually a very stunning x-ray. It is a complete interstitial pneumonia picture. And so that's a dead giveaway that it's a mycoplasma pneumonia. However, the formal diagnosis is with cold agglutinin assay. So that's the best, that's the most accurate test for mycoplasma pneumonia. The treatment for mycoplasma pneumonia is a macrolide, so azithromycin. So I would say that at any time you have a patient between the ages of, say, 15 and 28, or 30 even, that the best therapy for anybody, regardless of what kind of pneumonia you think they have, would be a macrolide. And that's simply because a macrolide will cover strep pneumonia. It will also cover mycoplasma pneumonia. So legionellosis tends to occur in older adults and smokers, and the classic vignette is that they're exposed to air conditioners, but that is not something that you're always going to be given because that's such a dead giveaway. So what you should think of is the fact that legionellosis is a pneumonia that is accompanied by some GI symptoms and by some neuro symptoms. So those GI symptoms include nausea, vomiting, diarrhea. The neuro symptoms often include uncoordination, imbalance, unstable gait. They also tend to present with relative bradycardia, so they might be less than 60, or they might be very febrile and be normal, whereas you would expect a very febrile patient to be tachycardic. Any patient that's older that has GI symptoms and anything that remotely appears to be a neurologic symptom should get a Legionella urine antigen. And that Legionella urine antigen should be reserved for those specific cases. So don't go too test happy on this. It's patients who have pneumonia-like symptoms who also have a GI symptom and a neuro symptom, and they're older. The treatment for legionellosis is doxycycline or a macrolide. So this is the walking pneumonia that I told you about. This is obviously a very dramatic chest x-ray, but the reason I say dramatic is because these patients aren't usually really that sick feeling. They're not feeling great, but they're not feeling as bad as this looks. So Coxiella pneumonia, you're going to have to be told this on the USMLE. I can't imagine any other way. This is so rare, but exposure to sheep placenta is Coxiella pneumonia. This is Coxiella burnetii, and this is also what's known as Q fever. The diagnosis is with serology, and treatment is doxycycline. So if you got that patient in there that says that they work around sheep placenta, then you should be getting a serology for Coxiella. Pneumocystis jirovecii pneumonia occurs in HIV and AIDS patients, particularly very ill HIV/AIDS patients. These patients will be very, very, very hypoxic. Any patient with HIV and AIDS that comes in with fever, sputum, and cough, they should always be getting, after you check their CD4 count, or if they're very hypoxic, if they're very sick, you should be getting bronchoalveolar lavage, which is how we check for pneumocystis jirovecii pneumonia. That is our means of diagnosis. The treatment for pneumocystis jirovecii pneumonia is trimethoprim sulfamethoxazole. You can also use pentamidine in the case that the patient has a sulfa allergy. Now, you should know that dapsone and atovaquone are used also for pneumocystis jirovecii pneumonia, but they are not used for therapy. They are used for prophylaxis. So patients who have a low CD4 count, who have AIDS, they are given dapsone or atovaquone to prevent pneumocystis jirovecii pneumonia. But that is not therapy. Therapy is trimethoprim sulfamethoxazole or pentamidine. GBS pneumonia, that's Streptococcus agalactiae, and this is the #1 cause of pneumonia and sepsis in neonates. So this is really sad. The mother is GBS positive. She didn't get checked. She had poor prenatal care. She didn't get penicillin before birth. Baby came out of the birth canal, or through C-section and acquired sepsis. And the sepsis doesn't have to happen right away. It could happen a couple weeks afterwards. This can be fatal. It can also cause meningitis. And this is the reason why it's always important for the mother to be swabbed for group B strep. And if she is GBS positive, or if you don't know, if you've got an expectant mother coming in to labor and delivery and you don't have a GBS status on her, she should be getting amped up with penicillin. As I mentioned, this can be fatal for the neonates, so the risk to benefit ratio here is obvious. In the case that a neonate, so 0 to 2 months, has pneumonia, you're going to treat them with gentamicin or rifampicin. And then Klebsiella pneumonia is associated with alcoholics. This is the current jelly sputum. So this can be treated with any of the third generation cephalosporins, so like ceftriaxone or cefotaxime. Now remember, this isn't current jelly stool. What's current jelly stool in a kid? That's intussusception. So current jelly is seen in 2 different ways in medicine. Okay, when do we vaccinate a patient for pneumonia, the pneumococcal vaccine? Well, really, you should vaccinate anybody who requests to be vaccinated. Also, prison inmates should be vaccinated. And older adults, asplenia, immunocompromised, COPD, CHF. Why does that look familiar? Because those are all the patients that you would admit if they came down with pneumonia in the if they presented to the ED with pneumonia. Okay, so just remember it that way. Anybody who's at risk for admission, if they need to be admitted to the hospital for pneumonia, they should probably be getting the pneumococcal vaccine. In my opinion, everybody should be getting the pneumococcal vaccine because we all come into contact with, all healthcare workers should be given the pneumococcal vaccine because we all come into contact with this. But really, there's no reason that we shouldn't be vaccinating everybody. So older adults, asplenia, and the asplenia, by the way, is just simply because the spleen creates certain immunoglobulins which are going to attack strep pneumo. So not having a spleen puts you at increased risk of any kind of strep pneumo infection. And that, of course, includes sinusitis. Okay, so this is not necessarily USMLE material, but it is kind of good for using it on the wards. So the CURB 65, and this is just 5 criteria, which each count as a point. And the idea is if they are 0 to 1 point, then they can generally go home. If they are 2 points, then you should admit them. And if there are 3 or more points, then you should admit them and consider ICU. So the 5 criteria are confusion. Personally, I would admit any patient with confusion, but confusion would count as 1 point, and that's just defined as a mental test score of 8 or less. Urea greater than 7 would count as 1 point. Respiratory rate of greater than 30, so as I mentioned earlier, that's a sign of respiratory distress, so tachypnea, that counts as a point. Blood pressure, systolic less than 90, and then age greater than 65 years. So 0 to 1 points, you can probably send them home. 2 points, inpatient. 3 or more, inpatient, possibly ICU. And really, I would, this is just something that somebody came up with, a university, but just have the general knowledge that if the patient has concomitant symptoms, if they're older, particularly if they've got any kind of signs of sepsis or respiratory distress, basically if they need to be in the hospital, then you should be admitting them. And that's all.